Good morning, everyone, and I would like to thank Dr. Banavli and colleagues for inviting me here. So this is in the vein of a workshop. I thought I'll talk about concepts in phase 2 trial design for metronomic chemotherapy regimens. And you can see here, baseball is the only field of human endeavor where somebody can succeed 3 times out of 10 and still be considered successful. And phase 2 is in a similar vein. So the talk is designed for dummies, but before you take offense, it is also delivered by a dummy. I have no pretensions to being a statistician, but I'll try to discuss what I think should be appropriate phase 2 designs for metronomic treatment. So phase 2 trials conceptually provide testing ground for definitive phase 3 trials. And metronomic scheduling and dosing is usually not a new drug, but a new dose and new schedule. So I personally think that the pathway of development of metronomic schedules should largely and broadly follow the pathway that has been the case for new drugs. They are the phase 2 studies are generally limited in sample size. There are compromises in type 1 and type 2 errors, and most importantly, no definitive conclusions can be drawn from the study. The best way to think about the phase 2 studies is for them to be considered as gatekeepers to more definitive studies, but by no means definitive in and of themselves. So these are some of the designs, and some of you are probably conversant with some of these designs. I cannot discuss all of them in 20 minutes. What I will do is, although my remit is randomized phase 2, what I will also talk about are a few of the classic single arm phase 2 designs, because the randomization concept is of more recent origin and has basically evolved from the single arm design. So typically these studies have short term endpoints, for example tumor response. And a very important and defining feature of a single arm phase 2 study is the use of historical data, and that is used to formulate the null hypothesis, which is that the probability of benefit or response is P0, and the alternative hypothesis is that it is a response higher than the null response P1. So P0 is essentially the historical control response. And the single arm phase 2 study is only as good as the historical assumption, and I will show you how that is the case. And therefore perhaps the randomized phase 2 design is conceptually more appealing. So these single arm multi-stage phase 2 designs typically accrue in multiple stages. So for example, there is a go no-go decision at each stage, and you don't sort of accrue 500 patients and then analyze the trial. So this is the classic phase 2 design, and this was formulated I think about 45 or 50 years ago. Essentially the goal is to reject an ineffective drug as soon as possible. And so this is a typical design. So for example, if we wish to see that a metronomic regimen has a response rate of more than or equal to 20%, enter 14 patients in the trial. If none of the 14 respond, stop the trial and declare the regimen ineffective. If at least one or more respond, then go on to the second stage. And if you are wondering where this 14 came from, and those of you who are conversant with the law of probabilities, if you compute the probability of consecutive failures at the 0.8 level, then you will find that if the drug is more than or equal to 20% times effective, there is a 95% probability that there will be at least one success in the first 14 patients. So this is the sort of thought process when we design multi-stage single arm phase 2 designs. And Fleming is a later design, and essentially again, so what one of the features of the Gehan design is that I have not mentioned the type 1 error or the type 2 error, and there are no constraints on this sort of a design, and this is rarely used in the current day for most of the targeted therapies, immune therapies, as well as metronomic regimens. So let me, so Fleming actually modified the Gehen design such that the response rate of interest called P1 and the null response rate of P0 were constrained by the type 1 and type 2 error. And essentially it provides again for early stopping after approximately half the patients have been accrued if the results are dramatically negative or positive. And so this is the typical design of a Fleming stage 2 study. Reject the treatment if high probability that the true response rate is less than 5% and go on to the next stage if the true response rate is more than 20%, but unlike Gehen, constrained within type 1 and type 2 errors. And Richard Simon from NCI or NIH actually further optimized the Fleming design, and he suggested that there should be no early stopping for dramatic improvement in the outcome, because you want to accrue a larger sample size and have a more or have a tighter confidence interval. So this is Simon optimal two-stage design is one of the most frequently used and has been the classic phase 2 single arm phase 2 design. You can see here that if the response rate of interest is 5% or the response rate of interest is 20% and the null response rate is 5%, one has to accrue 12 patients in the first stage and 25 patients in the second stage, and the regimen will be declared effective if 11% of these all 37 patients actually respond. So you can put various parameters for P0 and P1 as well as for the for A1 and R2, and you can one will get various kinds of numbers. So essentially when one is designing a single arm phase 2 trial, there are two sets of decisions that have to be made. One is to define an appropriate P1 and P0, and this is the hardest part of designing a single arm study. So what should one consider, for example, in patients with triple negative breast cancer who have relapsed on 2 lines of treatment? What is a good response rate and what is a bad response rate? And there the use of historical data is particularly difficult, and one has to be absolutely sure about it. Second, one has to set the desired type 1 and type 2 error bounds, and most of us are very conversant with designing phase 3 trials with an alpha bound of 0.05 or even lower and a power of either 80 or 90%. But the common practice in phase 2 trials is to set both the alpha and the beta at 10%, which means that one accepts not a 5% but up to a 10 or even 15% possibility of a false positive result. But one wants to have a greater power because we don't want to reject a particularly promising regimen. So there are two issues with single arm studies. One is the use of response rates, and the other one is the use of historical controls. So let me first talk about historical controls. And as I said, this is a defining feature of single arm studies. Historical controls, for a variety of reasons, may not fairly represent the expected outcome in the current cohort being studied. And there is patient drift due to a variety of factors. There is a downstaging. The pathological characteristics have changed. There is a difference in the radiological evaluation of patients. There is interinstitutional variability. And in metronomic schedules, most of these studies or these patients are being tested in non-Caucasian populations, where historical data is actually sparse and not that robust. And patients on the new trial may actually differ from the patients in the historical cohort due to differences in prognostic factors. So for example, the historical cohort may have contained 80% node positive patients, and the current cohort may have only 60% node positive patients. How will one account for that in a single arm study? And even a modest misassumption in the historical cohort can actually increase the possibility of a type 1 error. So for example, if one is wanting to test an improvement in outcome from 50 to 70%, and if the actual control the response rate is 55%, the possibility of a false positive result goes up to 26%. So you can see this is a very nice review, 134 phase 2 trials, almost half defined as requiring historical data for design, but many of them did not cite the source of historical data and whether it was relevant to their own patient cohort or not. And no study incorporated methods to account for sampling error and defined whether their patients were akin to the historical cohort that was being studied. The other problem with a single arm phase 2 study is the use of response rates, and I think there was a discussion at the end of the previous talk. Response or tumor shrinkage may not be the best measure of activity of biological treatments, including metronomic regimens, and these types of treatments may improve progression free or overall survival through means other than direct cell kill. And of course, most of you know that in a variety of cancers, tumor response has failed to show a tight correlation with survival benefit. So PFS has become somewhat of a preferred endpoint for phase 2 studies. It is more statistically efficient than overall survival because it takes a shorter period of time to attain progression free survival, and there are several pros of progression based endpoints. It reflects biological activity and is more clinically meaningful than response rate, for example for treatments such as metronomic. But the biggest problem is that, first of all, progression is defined variably by CA125, by CT scan, by PET scan, by MRI, and all of that will change the estimate, the actual estimate of the progression free survival, and it is significantly influenced by the frequency of observation. So for example, in this particular example, if you see and if you measure the progression in one arm at 2 months, then 50% have progressed, but if you measure the progression, if you choose to measure the progression at 3 months, 100% have progressed. So just the act of observation from 2 months to 3 months or every 6 weeks to every 12 weeks changes the progression free survival. And because of this, there is a problem with estimation of progression free survival, especially when you don't measure progression by a clock. So this is fairly recent, 2005. This is a proposal for a randomized phase 2 screening trial, and this screening is not to be confused with cancer screening in the conventional sense of the word, but it connotes a gatekeeper kind of a function for these kinds of trials, and it essentially means a direct but non-definitive comparison of the experimental regimen against a randomized standard control arm within a trial of moderate sample size. There are 3 parameters to vary. So essentially, like I said, in phase 2 trials, you accept a larger type 1 error. It can be 10% or even 20%. The power is still either 90% or 80%, and one can game for various effect sizes in progression free survival. And for example, you can see here that if you set the alpha error at 10 and the beta error at 20%, and if you want a hazard ratio for progression free survival of 1.5 or 1 divided by 1.5 in favor of the experimental arm, then we need 110 patients in this study. But there is one more caveat in randomized phase 2 trials. Progression free survival can actually be categorized. So for example, instead of saying that you will compare the median progression free survivals in the 2 arm, you can say that you will measure the 3-month progression free survival or the 4-month progression free survival, and that is an actual percentage. The benefit is that when you categorize PFS at a precise time point, it is less prone to the bias of determination, as I said earlier. So for example, if we say that the metronomic regimen will improve the 4-month progression free survival from 40% to 60%, we are bound to measure progression within a window period of plus minus few days at the 4-month time point, and that is less prone to the bias of determination. And the problem here is that there is a loss of statistical power. When you compare 2 proportions, you use a binomial test of significance, and when you compare 2 survivals, you use the log rank test. And you can see here that for the same example, alpha at 10% and beta at 20%, and for the same hazard ratio, now you need 220 patients when one needed 110. So there is a balance. If you wish to reduce the determination or the ascertainment bias or the bias in performing the assessments of progression, one can categorize the survival variable at a predefined time point. So, there are several advantages of the randomized phase 2 design compared to single arm design. It reduces the selection bias, there is no use of historical control, it improves patient comparability and can incorporate survival endpoints in a fairly intuitive manner. The con is that it is statistically less efficient and requires a greater number of patients. So, you see here that for the same assumptions, when you do a randomized phase 2 study, you generally need about double the number of patients compared to a phase 1 study, and that is the disadvantage. Let me in the end give you an example of a study that we can design. So, suppose we wish to study an oral metronomic regimen of etoposide, endoxan and tamoxifen in platinum refractory platinum resistant but not refractory high grade serous ovarian cancer patients in 4 centers in India, and by definition they should have relapsed or progressed within 6 months of the most recent platinum regimen, and because of the nature of this disease they should be able to swallow and digest oral medication. So, design one would use single arm design, and we know the standard treatment in this sort of a scenario are single agents such as weekly paclitaxel, topotecan and so on, but more recently Avastin has also been shown to improve progression free but not overall survival in this patient population. So, the point of note here is that there is a lack of PFS or even response rate data in relapsed platinum resistant patients in India. So, for example, if I was to use a historical control, what median PFS or what 4-month PFS rate would I use for that single arm study? So, because of this consideration, I think a single arm study may not be the most appropriate design for this sort of a scenario. So, the hypothesis here would be that the oral metronomic regimen will provide a PFS benefit similar to Avastin plus chemo versus chemo, and that is the Aurelia trial. The hazard ratio was 0.48 for PFS in favor of Avastin, and the median PFS was 3.4 months versus 6.7 months for the addition of Avastin to chemotherapy. So, here is the design of a study, and I have taken the 4-month rates from the Aurelia survival curves. The response rate, the null PFS rate at 4 months is 45%, the alternative PFS rate at 4 months is 70%, and if we set it at alpha of 0.1 and beta of 0.1, we need 114 patients assuming no loss to follow up. So, let me end. Response rates are becoming less popular as an endpoint, and especially for an oral metronomic regimen to be evaluated, they may not be the most appropriate endpoints. Progression free survival or sometimes overall survival in very fatal diseases, and especially categorized survival endpoints, are one appropriate choice to get a signal of activity in phase 2 trials of metronomic regimens. Single arm phase 2 studies are sometimes appropriate and, like I said, statistically more efficient in terms of smaller sample sizes when historical data is of high quality and the patient cohort is similar. In most situations, however, the preceding is not fulfilled, and the randomized is an appropriate balance between pools of designing a phase 2 study. But one last caveat, the results of a study should never be considered definitive, and I need to take you no farther than the classic example of iniparib that was in triple negative breast cancer, that was shown to be superior with respect to overall survival in a 140 patient odd phase 2 study, but failed to prove its worth in the definitive phase 3 trial. So, with that I will end, and thank you very much for your attention.
Thank you, Sudeep.